Welcome to the September 1st, 2021 Board of Selectmen meeting. As a preliminary matter, I'm going to identify myself, John Jeffries, as Chairman Board of Selectmen, and Bob Springett, who is a member of the Board of Selectmen. Bob, would you identify yourself and let everyone know you're here?
Bob Springett, I am certainly here. Thank you,
When
John.
Robin Hunter enters the meeting, I will introduce her as well. So this evening, when we call your name, would you just identify who you are for the purposes of the meeting being recorded on Zoom? Please also take care not to share your screen as the meeting is being recorded. We're recording and conducting the meeting remotely as a continuation of the governor's orders from last year. This evening, we have two speakers who are scheduled. Ford Spalding, who is the husband of Chip Spalding, which is the most important thing that I could share with everyone, and the chair of the Carroll Building Committee, as well as the Board of Fire Engineers. Ford is going to be our first presenter this evening, and Dr. Kate Peterson is also going to be with us for our second agenda item. So Robin Hunter has just joined the meeting. When I can physically see, she joined and then left. Oh, she's back. Hello, Robin. Can you identify yourself and let everybody know you're here?
It's Robin Hunter. Apologies, the traffic was really bad with the rains.
So I don't know if everyone has the ability to look out a window as well as be on Zoom, but I have rain coming down sideways in the window that I'm looking at right now. So you are certainly forgiven, Ms. Hunter. Robin, I just went through the introductions, the formalities, the Zoom, and the protocol. So Ford has been introduced. Dr. Peterson has been identified as a potential speaker. Kate, do we have, I know that we've got citizens' comments during some specific sections of our any citizens to speak this evening who have with you prior?
No.
Great, thank you very much. So seeing none and having none in front of me, no hands being raised, we're going to move right to item 1.1, which is the presentation of the Carroll Building Committee. Just as a preliminary matter, I joined the meeting just on the meeting of the Carroll Building Committee that was held on Monday, just on as a phone call-in, just specifically not to run afoul of any open meeting laws, so no one could say that Bob and I were deliberating, as Bob Springett was present in the meeting as well via Zoom and heard the presentation from Ford. So I've had the presentation on Monday. Bob has had the presentation on Monday. Ford is here this evening to give us the cliff notes of the meeting. So without any further ado, Ford Spalding.
Thank you, Ford Spalding, Chair of the Community Center Building Committee. Actually, it was Phil Palumbo that made the presentation on the fee proposal for Fenwick McCready Architecture. It was the exact same presentation that he gave the selectmen on the 26th. I know Robin was interested in the comments and answers that came up on Monday night. I have to tell you, there were no comments, no questions. The building committee then moved to vote, and the vote was 5-2, 5 in favor, 2 abstained, and the 2 that abstained said they had not read the contract or the fee proposal, which they had had for about 5 days. So it passed unanimously except for 2 abstentions, and that's my report.
Unmute. Thank you, Ford. Bob, would you like to add anything to Ford's comments?
So I'm just going to ask Ford about 105 questions. So Ford, there was a lively discussion around the John, maybe you should put yourself on mute.
I thought I was, sorry.
Okay. there was a lively discussion. A number of people were looking at different aspects, not just of I don't think so much around the architect contract. But they were sort of poured over sort of, I think, the timeline that the architects went through. Is there anything that sticks out in your mind as of importance that the board might want to know based on that give and take during the meeting?
Well, from the timeline, we're on time, and there was a fairly lengthy presentation by Phil Palumbo based on Luciana Berti's request for the budget presentation, which he presented, which did include timeline and all that, but there's nothing that that causes any concern or comments. And that will be a monthly report that's given every month.
So Ford, when do we expect to have cost estimates done?
I have to look at the schedule, but I would think, I think it's by the end of next month. And that's one set of cost estimates, and there'll be another later on, but there'll be cost estimates by the end of next month. That's what we're getting ready for. And
so that'll be an important milestone, I think, for everyone. Yes.
Yep.
I mean, otherwise, if I remember the conversation, the plan was laid out pretty much the same. You know, the timeline was laid out pretty exactly, going from where they are right now, you know, right through spring of 2022.
Yeah, there are no changes. We're on target and we're moving ahead. We have done some exploration in the building. We've gone into the walls. There's nothing really that we didn't know about in there. We've dug around, partially around the outside of the building. There's nothing alarming there. We might not be able to lower the building, the front of the, as much as we'd like. That's the ground level, but we're only going to miss it by about a foot.
Thank you, Ford.
Yep.
Robin?
I don't have any questions. You know, what I was interested in was just the deliberation of the building committee. And I think, you know, Ford, it sounds like from the vote that everybody was on board, and Bob gave us a little bit of color, so I'm good.
Yeah, Robin, what's interesting is when you look at the cost of construction, that's what you're really looking at. We are in line with the last few projects that they've done, which are the Hadley Community Center, the South Hadley Community Center, the Long Meadow Community Center. We're within 0.5% or 1% of our costs, and we're a year or two later. So we're right in line.
Okay.
Any other comments, any other conversation with respect to this matter of authorizing Chris to move forward with the extension, the contract extension with Fenwick McCready Architectural? Chris, is there anything I have to add to the motion? Is that essentially the essence of the motion?
Yep, just authorizing the town administrator to sign any contract documents related to FMA.
So I move to authorize the town administrator to continue to extend the discussion, to execute discussion and continue the contract extension with Fenwick McCready Architects. And is there anyone else that needs to be added to it, Chris?
No,
No, sir.
No. Okay. And ask for a second.
I will second that.
All in favor? Aye, John Jeffries.
Hi, Robin Hunter.
Hi, Bob Springett.
Ford, thank you.
Thank you all. I'm glad we can retain them, because if we didn't retain them, we have another problem. So good.
Exactly. So thank you.
Thank you.
We are going to move on to our second item, and I'm going to introduce Dr. Kay Peterson. Kate, you're going to be the first speaker, and I see that Jerry is joined as well. And Dr. Kruskal as well. So I'll let you go first, and thank you for being with us this evening. I will say to the other members of the board, to our town administrator and assistant administrator, as well as everybody listening, that Dr. Peterson and I had a conversation earlier today. I outlined what the Board of Selectmen would like to see in terms of data, to the extent that the Board of Health can present to the Board of Selectmen as robust set of facts and data that they have to their disposal relative to a cause and effect of a proposal that they are about to present to us this evening. So, Dr. Peterson, the floor is yours.
Thank you, John. So the Board of Health would like to talk tonight about our plan to issue a mask wearing mandate for Dover because of the rising rates of COVID in Massachusetts and in our area as well. So we are in something of a surge in Massachusetts. We are in a surge, and what we don't know, of course, is whether we're at the beginning, the middle, or the end of it. We hope it's not going to last long, but we have no idea. But what we do know is that the surge is due to the Delta variant, which is responsible. Kate, don't start the slides yet, please. The Delta variant is responsible for virtually all cases in Massachusetts at this time. It's very transmissible, as you all know. And I apologize if I'm talking about things you already know, but I'm going to assume that at least some people want this reviewed, and that some of you haven't heard some of what I'm going to say. So bear with me if it's something you already know. But the Delta variant is probably somewhat more than twice as transmissible as the previous variants have been. And we've learned that fully vaccinated individuals can become infected with COVID, with the Delta variant, and are capable of transmitting it to other people. They have a high viral load and therefore are just as likely to spread the infection as people who are unvaccinated if they get the infection. However, being fully vaccinated means that your risk of acquiring the Delta agent is much less than it would be otherwise if you were unvaccinated. And if you do acquire it, it's much more likely that you will be asymptomatic or very mildly symptomatic, and much less, extremely less likely that you will become seriously ill or die. Though even, we know that there are breakthrough cases in vaccinated people that have been serious and have resulted in death. So we know you can't assume that vaccinated individuals now are incapable of spreading COVID. We have to assume that anyone can get COVID and spread it to other people. So we're seeing rising case counts in Massachusetts, all over the country, but Massachusetts and in Norfolk County and in Dover. And Kate, could you now display the first slide? I'm going to start with some figures from the Department of Public Health. And the first slide is this display of the 7-day average of confirmed cases. And you can see that we hit a low in June and that things have been rising since then. That what appears to be a little drop at the most recent data points is not indicative of a real decline. Things are still heading up. Could I have the next slide, please? And this is the 7-day average of hospitalizations in Massachusetts, also rising. And then Kate, the next, please. And this is the 7-day average of confirmed deaths. And you can see that this has risen only slightly. And that's in part because we know that there's a long lag time between the development of cases and when people die from them. But we also know that people who develop COVID who've been vaccinated are significantly less likely to die. So we're likely to see more deaths even as the weeks go on in this surge. We're likely to see fewer deaths than we would have in times when people were not vaccinated, such as you can see the two peaks in this graph from June of 2020 and December as well. Next slide, please. This is a graph, and it's a little hard to read, but this is the average daily rate per 100,000 people for Dover. And you can see that the rate has been rising pretty rapidly. It's not nearly as high as it was at its worst, which was in the winter, when we had about 43 cases per day on average per 100,000 people. Our rate is now about 12. Next slide, please. This is a display of our weekly cases over the past month and a half, approximately. We have been very flat in the number of cases through the early part of the summer, late spring and early part of the summer. And then in late July, things started to take off. And the next slide, please. Today, I spoke with our public health nurse, Alyssa Kaiser, to get an up-to-date picture of where we are. She said that over the past week, we've had 7 new cases. Over the past 2 weeks, we've had the cases we've seen have been mostly in groups of people aged 12 to 18 and 30 to 50, though we've seen people of all ages with infections, but it's much less common now to see COVID in seniors in Dover because almost all seniors are vaccinated. And I suspect our seniors are very cautious about behaviors that help mitigate the risk of COVID infection. So what Alyssa said is that, as usual, the cases are a mixture of vaccinated, unvaccinated, and partially vaccinated individuals. She didn't break that down for me this time, but when she last did a couple of weeks ago, the majority of cases were in unvaccinated people, but there certainly were some in the other categories. We certainly have breakthrough cases in Dover. With regard to the recent data, she said that the cases in teens are usually related to unmasked social contact. There are a lot of household cases, always. Those are the clusters that we are most likely to see, and there have been no other clusters in recent weeks. She did point out something that I alluded to last week in the COVID alert, which is that some cases in our town, and this is true in every town, have been uncooperative with contact tracing, which makes it difficult to advise people who may have been exposed to test themselves and quarantine if they need to. I will also say that Alyssa said that all the communities she works with are seeing significant increases. We're not alone, and this is a problem throughout the area. I want to talk a little bit about masking. So you could go to the next slide, please. So why is the Board of Health talking about a mask mandate? Well, really because masks are effective. They, when instituted, they result in fewer cases, fewer hospitalizations, and fewer deaths. They protect people who are vulnerable, and in particular, those people are children, immunocompromised individuals, and unvaccinated adults, but they also prevent breakthrough infections in vaccinated people. Masks also protect our schools because they help prevent large outbreaks. There have been some reports about schools and masks, and one comes from a county in Florida where something like 1,600 children became infected, and 8,000 children in the school system had to quarantine. In Atlanta, there was an outbreak that required quarantining 23,000 students. And in contrast, there was a report from North Carolina, which had universal masking required during the last school year. And during that time, there were 40,000 students had to be quarantined because of exposure to cases. And of those quarantined people, only 363 developed COVID, which is an incredible statistic, and makes pretty clear that masking is helpful, because that report noted that very few school systems in North Carolina had done any work on their ventilation systems, and there was not very good social distancing in North Carolina. So go to the next slide, Kate, please. So in terms of other data, this is too small to read, but I want to just point out that there are numerous studies reported in this table that indicate that very shortly after instituting mask mandates, many communities that looked at it found that their case rates dropped significantly. I'll point out a couple of studies that are somewhat different. The first is there was a report that you may remember from a number of months ago when two hairdressers in Missouri who worked in the same salon went to work sick, and both had COVID. They were symptomatic, they wore masks, and of the 67 people who were studied after contact with these women, none developed COVID. And that's not proof that masking works, but it was a very suggestive study at a very early stage in the pandemic, and gave a lot of people, I think, hope that masking really did work. And then there's a report from Kansas, the Van Dyke study, that showed that counties in Kansas that institute a mask mandate saw that their case rates dropped significantly compared with those in those counties where there was no mask mandate, and the case rate increased. And then you probably all read recently about the teacher in Marin County who was symptomatic, went to work, wore her mask, took it off to read a story to her class, and infected half of the students in the class. And the ones who sat in the first two rows closest to her were the ones who were overwhelmingly likely to be infected. And then people say, well, where are the randomized controlled trials of masks? And I just happened to discover that there in the Washington Post today is a report about a not yet peer-reviewed study that's going to be published in Science once it's completed the peer review process. That is a report of a randomized control in Bangladesh involving over 300,000 people who were randomized either to getting coaching about masks and free masks, and they were compared to a group of people who got no mask intervention. And there was a significant reduction in infections in the mask intervention group. So I think the evidence now is hard to argue with that masks work. They're not perfect, and what we rely on is a layered approach of masking, social distancing, improve ventilation, having people avoid contact with other people when they have symptoms and getting tested. But masking is a really crucial part of this and is, I think, really vital for the health of our community. I know that masking is controversial in this country and is elsewhere in the world as well. But what is important to the Board of Health is really what is most important, is what works for, what is going to promote the health of the population of Dover, what is best for the common good in terms of health. And it's our opinion that that a mask mandate will help reduce the risk of infection being transmitted in town. We're in the process of drafting a public health order that will mandate masks in municipal buildings and also in buildings that are open to the public elsewhere. Once that's been instituted, it's something that we will review at every meeting going forward because it's not something that should stay in place any longer than it needs to. So, you know, if everything's going well, hopefully this this current surge abates soon, we'll be done with it very quickly. But if not, and things continue to go poorly for this area, then we would keep it in place until there was significant improvement. So I think that's a summary of what we want to do and how the data support that. I'll also put in a plug for masking everywhere when people are outside their own homes and indoors, not outdoors. Outdoor masking is important at this point in most circumstances, but certainly the Board of Health recommends that people mask in all sorts of places, but we want to be sure that masking is going on in public buildings and publicly accessible buildings in Dover.
Thank you, Dr. Peterson. Are any of the other members of the Board of Health going to make a presentation or going to be a part of the presentation, or would you like to take questions at this point?
Can we go back to one of the slides, Kate?
Sure.
The one, there's a slide that shows the seasonality evidence with a dramatic peak in the winter.
Jerry, just because we're being recorded on Zoom, would you just identify yourself, please?
Yeah, I'm Gerald Clark, the chair of the Board of Health and a retired professor at BU and MIT. No, I can't manipulate it, so I'm going to have to, I'll tell you when you got into it. It's a very dramatic peak there you go. Okay, so the point to this story is to understand that this dramatic increase occurred when most people were indoors and therefore in close contact. Normally, in other years, in such a time period, we would expect to see somewhere between 30,000 and 70,000 mortalities, deaths in the country from seasonal influenza. Last year, we only had 1 in 5, 20%. Why? Well, part of it was, of course, people weren't out gathering. There wasn't the opportunity for the same transmission. And on a strictly anecdotal basis, you could argue that it was because so many people, when they were in contact, were masking. So that's one piece of the information. This year, there is great concern that without last year and exposure to the influenza virus, which mutates in a fashion very comparable or even more so than the COVID virus, we may expect to see even more cases in the influenza. All the more reason as a coincident matter to be aware of this. So the question then is, well, if I'm fully vaccinated, why do I have to care about this? Kay has done a phenomenal job in this report. I would hope everyone understands everything. There's no reason to have not understood what she had to say. One thing that tends to get muted is the idea that people think that if they have been vaccinated and therefore believe they cannot be infected, that they in fact therefore cannot infect others. And that has been proven to be untrue. The term is used vector, V-E-C-T-O-R, someone who carries the illness and transmits it to someone else without necessarily themselves being infected. And that is something that can occur. And the masking dramatically goes to eliminate that possibility. So I think overall, the presentation that Kay has done should be convincing to just about everybody. Most people know I am not a politician. I am a numbers person. And I think the numbers truly speak for themselves. Thank you.
Thank you, Jerry. Dr. Kruskal, would you like to make any comments before we begin question?
I fully support what Dr. Peterson say, and I don't think there's any need for further redundancy.
Great, thank you, sir. Bob, would you like to have questions or comments? Would you like me to go first, or actually, why don't I just give a couple of quick questions from constituents that reached out to me in preparation for this evening. And Kay, I'll direct the questions to you. If you feel appropriate, you could redirect to Jerry or to Steve. So the first question, Dr. Peterson, is mandate versus recommendation. Our initial conversation and our initial thought is, as the board of health was going to make a recommendation for mask wearing. And the question goes to the statistical differential between mandate and recommendation. Specifically, do you feel, or how do you feel that a mask mandate versus a mask recommendation is going to statistically get you to the place that you feel comfortable? And as you've gone through this particular exercise, why do you feel the mandate versus the recommendation is necessary?
We have been recommending mask wearing for more than a year. And we know that more people wear masks when they're mandated than wear them when there's no mandate. We know that mandates reduce the risk of transmission of COVID in communities that institute them. So we feel that it's important to reduce transmission in our community.
Okay, so back along the same lines, you and I had a conversation earlier today about some of the communities that have instituted a mask mandate. And then we also discussed some of the communities who have rescinded their mask mandate. Specifically, we talked about Provincetown, how Provincetown at the very beginning of the summer, due to the transitory nature of their population in the summertime, as with most of the Cape, there's a lot of people moving into small towns very frequently, typically 1 or 2 weeks at a time. So the population is changing rapidly. Provincetown instituted a mask mandate, and they just lifted their mask mandate yesterday, effective today. So Dover is the opposite of many of the towns who instituted a mask mandate. They have very high degree of turnover of their population. our population is the opposite. We do not have that statistical change in population. So if Provincetown is lifting their mask mandate, and they're the opposite of Dover, why do you feel, why does the Board of Health feel that this is the right time to mandate the mask wearing?
It all has to do with the slope of the curve, John. It has to do with how rapidly we're seeing increases in the number of cases. Provincetown, I don't know the precise numbers in Provincetown, but I've read that they're falling rapidly and that they're down to acceptably low levels. Ours are going up with time right now.
Would you say that from a statistical standpoint, that clearly would have to do with the number of their population triples or quadruples in the summertime, and then as soon as Labor Day rolls around, their population drops to the normality of their full-time population? I would assume that that's true in Nantucket, the Vineyard, Hyannis, any of the tourist towns along the Cape and the Islands. So I would suspect that some of that drop has to do with just sheer numbers in population. Again, I know that, and you showed, and Jerry pointed out to it, that our numbers have risen from 1 or 2 in the town of Dover to 4, 5, and 6. I'd also point out that that's probably due to the fact that kids came home and were with their friends, got sick, and then their interfamily dynamics. And now they're probably going to go back to school or for that period of time. So certainly, wouldn't that trend follow the same trend as the flu or any other communicable disease?
John, most of our cases are acquired by community transmission and not imported from outside the town. I mean, somebody imported the first case, right? Since we had, since that period of time when we had none, or maybe it's been at a low level and endemic in the town all along, but we are seeing spread within the town. We're seeing rising number of cases. However they get here, they're rising, and every case has a significant, there's a significant probability with any one case that it will spread to other people, and households are very vulnerable, as you mentioned, but so are friends, and the cases in the adolescents are all. I mean, I actually don't, I'm not privy to knowing exactly who has a case and how they got it, but I do know that Alyssa, our nurse, our public health nurse, feels that social interaction among teenagers in Dover is a big factor causing the cases in that group. I would say unmasked social interaction. It's one of the hardest groups to deal with, really. But you know, the other big group are the 30 to 50-year-olds. There are a lot of cases among them as well.
Thank you. Robin, do you have questions, comments?
So my questions are enforceability. If you have a mandate, how do you go about enforcing it? Like, for instance, I noticed a lot of towns have made a distinction between they'll have a mandate in municipal buildings, but maybe not a mandate in all indoor buildings. So I'm just wondering, if we were to put this mandate in place and somebody walked into the townhouse without a mask, what can we do?
Jerry, do you want to?
Yes, we've talked about this, and there actually is a process that has been used elsewhere. And I'll give you 2 separate examples. Here in Dover, retailers, and there are very few,
Right.
have in the past, when masks were absolutely necessary, have essentially told customers that they can't enter the building without one. Now, that is the responsibility and the authority of the private owner. And that would remain true, even with a mandate. But it would give the force of argument to the private owner that indeed there is a governance involved supporting that person. When it comes to the municipal buildings, as I talked with Kate this morning and walked this through with her, this is Massachusetts General Law, Chapter 111, Section 31. The proposed mandate would be a Board of Health regulation. The town code provides for a significant financial fine in the case of any violation of a Board of Health regulation. But that's not really what we want to do.
Right.
What we want to do is prevent someone from coming in and being demonstrably dismissive of the mandate and with disregard to the public health. So there is a much simpler process. It's one that's used by retail establishments when they have either disorderly, disruptive, or bluntly thieves in a building. And that is, if someone came into town hall and was approached by a town employee, not aggressively, and said, look, sir, look, madam, we really must have you wear a mask if you're going to stay in the building. And if they are dismissive of that, there is no need to get into an argument other than to explain to them very simply, if they choose to do that, they are in violation of the regulation and they are subject to the complaint of civil trespass, and we will call the police to enforce your removal. And that is done constantly in the retail establishments around this country and in this state. It is a simplistic, straightforward method to resolve the problem. It isn't a criminal case. It isn't any type of record, but it clearly is instructive, and it puts the enforcement where it belongs in the police authority and does not put a burden on the town employee.
Okay, so I have one follow-up question. And thank you, Jerry, that was a great explanation. If we have a mask mandate, thinking back to the way things were in the workplace. So if you're sitting in your office, not interacting with somebody, would you be required to wear a mask? Or would you only need to be required to wear a mask if you can't maintain 6 feet apart?
I think we've seen both directions taken, not obviously in contradiction with another, but rather some, particularly retail establishments or offices, business offices have taken the attitude of, if you are indeed isolated, you're sitting in your own office and no one's coming in, there is an argument that you really don't need to put a mask on. Conversely, we've seen some municipalities now, there's been widely distributed to all of you what the orders have been from other municipalities. Some of them haven't been as free on that and have required permanent masking simply because one could be forgetful. Someone has a visitor walk in and you tend to forget that you didn't put the mask on. So I do think the board has to come to a decision on that specific question. I'm not convinced that we have reached a firm conclusion one way or the other on the issue of, if someone is by themselves in a private office, do they need to be masked? My own personal opinion, as I said to Kate this morning, was I just as soon wear the mask myself all the time and just be done with it.
Oh, I certainly, I think, as you mentioned, the data speaks for itself. And I think it's easier if you have a mandate rather than make it voluntary, but that's just my own opinion.
May I speak to that?
Sure.
Robin? I think we saw the failure of recommendations all this past year. We had the situation that occurred as vaccination began, where the recommendation, or even in theory, the executive order of the governor was that if you were vaccinated, you didn't have to wear a mask, but if you weren't vaccinated, you had to. And there was no methodology in place to reconcile who was and who wasn't. And therefore, it was very easy for everybody to say, oh, don't worry about it. I don't need a mask. And I don't think we want to go back to that.
Those are my only questions. You know, it's just society and behavior and what's the right thing. I think there's nobody can refute the evidence that wearing a mask slows down the spread of COVID. I mean, there's just no refuting that evidence.
Thank you, Robin. Bob?
I have some observations. I guess fundamentally, it's not clear to me that the remedy fits the problem. And again, I agree with Robin. There's a lot of data that says masks slow the transmission. The problem is that, Kay, in your presentation, you were not focused on Dover specific. I mean, you were talking about Atlanta, you were talking about Florida, you're talking about places where vaccination rates are really low. I looked at a New York Times article and where Massachusetts stood on in terms of the highest to lowest number of cases of COVID in the country. Well, the highest one, we were 47th in that review, 23 cases per 100,000. So I really do think that with, and again, talking about a surge from 0 to 4 or 4 to 6 yeah, 0 to 4 is an infinite increase, but it's 4. And whether it's 4, 5, or 6 new cases, it's 4, 5, or 6. If you're talking about community spread and you're talking about that within the household, there's not a lot, people are not going to wear masks in their houses. So it's not clear to me that we have the right remedy. And what I would think would make great sense is to take a step back, reconstitute something like the COVID task force, and go through this with Dover specific information before you guys go forward. I would also point out that in terms of the 12 to 18 years old and the kids in preschool, all the kids, because of the Department of Education, are going to be masked in school. Is that right?
Yes.
Yes. And so that's a big cohort. And also, as you pointed out, a high, the people who actually do, teenagers are hard to deal with. They will not listen to your mandate, or they'll do what they want to do. And community, so you're not going to attack that sort of end of community contagion. So I think that we've got to be able to look at this in a balanced, nuanced way. And I really don't think we want to get into pulling in the police for unruly people. I don't want to do the airline thing. But I do think if we sat down together, get people together in the townhouse, think through the different aspects of recommendations versus masks and what we would and wouldn't do, we get a broader perspective, and I think it'd be helpful for all. Now, in my particular case, just as a consumer, right, I'm fully vaccinated, and whenever I go to a retail organization or even into the townhouse, I wear a mask. I don't do that because of COVID, and I'm afraid of COVID or any of that stuff. I do it out of respect for the people who are providing the services. And when we call these people essential workers, and for people in a grocery store who are seeing hundreds of people a day, I think it's very important to keep them safe. In the townhouse, unlike Provincetown, I don't think we have that sort of wide open, high duration, high density environments, which, if you go back in the day, the indoor problem was generally around duration and density of events, bars, crowded restaurants, choir singing in churches. And so I'd like to really understand, in like I said, the townhouse, It's basically empty. The police department, the highway department, the library, we don't have that kind of environment. And so before we go ahead and make a big step, I really want to sit down with people and go through each of the elements and do it Dover specific, rather than sort of make a broad brush sweeping statement about the data. And Kate, I know I sent a thing about the data to John and Robin, to members of the Board of Health. And the best thing we know about data is that it's unreliable. And so, again, I propose that we sit down and work this out in the best way in the interest of Dover, bringing into the equation people who work in Dover and have points of view, so that whatever you guys ultimately decide, it would reflect a broader consensus view. I'm done.
There is one thing that we tend to misunderstand. We tend to think of most people in Dover who have been eligible to be vaccinated as having been vaccinated. And well, okay, as long as we understand that we're not talking about the young who only recently, the teenagers, nor those who are very young who aren't eligible, or those who are in an immunocompromised situation that they can't receive the vaccine. But the most recent data that was published toward the end of August by the state on cohorts of age groups and the percentage vaccinated yielded a very surprising piece of information. And that was there in Sherborne, almost all age cohorts are 95% or more vaccinated amongst those who are eligible. In Dover, you would think it would be the same. But rather interestingly, one age cohort is only about 80-some%. And it's a surprising age cohort. And it's the 65 and above to 75 age group that has been less experienced in getting vaccinated. I don't attempt to offer any explanation, but it offers a group of people, some of whom are very likely to be coming into the townhouse. It offers a group of people who, for whatever their reason, have not been vaccinated, and they offer a reservoir of opportunity for the disease.
Yes, Jerry, but you got to weigh that against their duration and the density. The fact there is risk in the world. There is risk to get COVID. You know what? We're not trying to eliminate risk because you can't. And so the question for me is, what is the appropriate set of steps to minimize risk in a way that is good, not perfect. There is no perfect. And I really want to avoid putting ourselves in position, perhaps unnecessarily, and that needs to be determined. Like the airlines found themselves with unruly passengers. Now, there are people who have strong views about their individual rights, and they resent having people tell them what to do. So if we can find a satisfactory way of avoiding that particular problem while protecting the health and welfare, fine. But I think that requires a broader perspective than the 3 members of the Board of Health and the Sherborne Board of Health, which we're just a bigger community. And I suggest, again, pulling together the COVID-19, a subset of the COVID-19 task force to have that discussion.
May I speak?
Okay,
Sure.
sure.
I have a number of comments in response to Bob. One is that though he used the word unreliable to talk about data, the data that we have, the data that I've presented is quite reliable data. No data are perfect, but I have I've curated what I've presented to you, and it's very telling data. I would also say that the fact that the absolute number of cases in Dover is small reflects only that we're a small community. What's important is the rate of rise in cases. And one of the important principles of dealing with the epidemiology of communicable disease outbreaks is looking at the rate of rise and understanding the concept of exponential growth in something. And we are having a rapid rise in the number of cases, even though it's only 7. That's a lot more than we used to have. And and we're seeing when you have a rate of rise like we have, then what you know is that every case is, the average case is creating more than one new case. It's called the reproduction number. And if you don't intervene, then things will continue to rise. And we're already, things are rising in our current situation. And you say, well, what else can we do? We can't push people any further apart in our municipal buildings. We could ban people from coming into the municipal buildings altogether, but then maybe that's too extreme. Wearing a mask is the next logical step to increasing our risk mitigation strategies so that we stop this. We stop the increase in cases. You're right that you can never eliminate risk, but you can make reasonable interventions. And you also, when you're dealing with a communicable disease outbreak like this, you add layers of protection if you're not seeing a response. And we're not seeing a response to our current interventions include social distancing and recommending masks and recommending vaccines, but things are going in the wrong direction. So we need to be more aggressive about what
we need to understand why, Kay. John raised several points about why. So again, I don't want to get into a debate here, right? Because
well, you are.
Well, so, I don't want to. I want to move this to a different environment so we could talk this through. Because, you know, again, the absolute numbers are small. In the past, the vaccination rates were much lower. It's not very clear to me that what you're proposing is consistent with the threat. And there are other people who I think feel the same way. And so I'd like to have that explored. And I can't do it tonight here.
Okay, I would like to make one more comment in response to what you said earlier. And that is, you talked about the people who resent mask mandates, and I want to say that there is a very large, probably larger group of people out there who resent not having mask mandates. They're more silent. They're less politically active. At least they have been. In some communities, they're becoming more active. But it's incorrect to think that the only people who are unhappy are the people who are confronting mask mandates, because there are lots of people on the other side as well. And I would say that, well, I think I'll stop there.
Thank you, Dr. Peterson. I just a couple of quick comments with regards to the conversation, the most recent part of the conversation, both for all the members of the Board of Health and from all the members of the Board of Selectmen. Dr. Peterson, you said earlier that the Board of Health focuses on the health of the public and the health for the common good. I think that's what you said. I may have missed it just a little bit, but pretty much I believe that's exactly what you said. And what we're trying to balance is with something that you just said about intervention. Then you just said reasonable intervention. And what we want to be sure that we thoroughly understand is we appreciate We have the utmost respect for your time, your intelligence, and the thoughtful, I would add, empathetic way that you have approached these subjects. We also want to balance, as Bob and Robin have both said, the public, the common good with common sense. And we want to make sure that reasonable intervention is thought through for all of our constituents, for all of our family members, for everyone in the town that you and I, the collective we, represent. So while we're all on the same team, we want to make absolutely sure that the reasonable intervention is reasonable for everyone. I would really like, as Bob said earlier, to have the COVID-19 task force revisit your recommendations before you make anything before you mandate anything with respect to age groups, cohorts. For example, I just got a text while you were speaking, Dr. Peterson, just now about age. And Robin spoke earlier, Bob spoke earlier about age cohorts that will be mask mandated in schools. If a 4-year-old or a 5-year-old walks into the Dover market, will that 5-year-old or 4-year-old or 2-year-old be mandated to wear a mask while they're with their mom or dad or caregiver at the Dover market? Is that, we really would like to balance that before there's a mandate. Robin, Bob, do you have any other comments that you would like to make before we move on?
Well, John, I just want to clarify. I personally, and something that Bob said, I respect mask mandates. I believe that if it makes people feel comfortable, regardless of whether I'm vaccinated or not, I will wear a mask in a public setting, because there are people that have young kids at home that aren't they can't get vaccinated, and I am sensitive to that. So, I personally, as I said, I do not have an issue with a mask mandate or with wearing a mask in a public setting.
John, you're muted.
Okay, go ahead.
I want to say that our goal is not, the Board of Health's goal is not to make a proposal that people who are not in public health find reasonable. It would be great if you found it reasonable, but our goal is to promote policy that protects the public health. And that's all we're thinking about. We don't have any political agenda, and we know that the politics are intense here, but we're following the science and we're following the interests of protecting the health of people in our community. We have vulnerable people. We have people who've been sick. We've had people who've been hospitalized, and we're not at liberty to talk more about the impact of COVID on our community, but it would be, if this surge continues and cases rise in Dover, it will be inevitable that we'll have somebody die eventually of COVID, if that hasn't happened already. And we also know that there are lots of other impacts, and if the number of cases rises and we have transmission in the schools, hopefully we won't, that will have another serious impact on the community. But you can't say that, well, we can fix it with one age group and not with another. I told you about the teens, and I told you about the 30 to 50-year-olds because they happen in the past 2 weeks to be the group that they happen to be the groups that are were most affected over the past 2 weeks. But we've had cases in toddlers and we've had cases in people in their 90s. And anyone is susceptible. We also don't live in a bubble. We're not just Dover. We have people coming into our businesses from other communities where there may be higher case rates. Even if you assume that somehow you couldn't get it from somebody who lives in Dover, there are lots of people out from elsewhere who come to our town, but there are lots of people in Dover who get COVID. And there are more of them now. For every 7 cases that we know about, there are probably 2 or 3 times that many that are really in town. There's a lot of asymptomatic COVID now because of Delta. So just to summarize, we're really not interested in, we're happy to talk with you, but we're not interested in making a decision based on what is going to make people comfortable or make people who aren't in public health think we're making a reasonable decision.
Okay, what does the state do? What's the state's protocols right now
About what?
about COVID, masking, etc.?
The state says that anyone who is in an area of, what's the word, either high or moderate transmission, those aren't exactly the right terms, should wear a mask indoors.
What's the CDC?
I am not sure. I think it's the same, but Steve or Jerry, do you recall? It's the same as the states.
I think we're going down a rabbit hole when we talk about what is the state's attitude. I think
No,
we should,
protocol, Jerry, not their attitude.
okay, protocol. The state in this entire period for 17 months has put it upon the local communities to establish a rule, to establish a mandate. The state has been abysmal in asserting authority. There has not been a situation where they have mandated, but rather recommended. We hear that all the time in the meetings with Department of Public Health. So be careful when you try to compare to the state. I will not attempt to explain why the state acts the way it does. I can only tell you that it is very typical of so many aspects of this state's government to put the burden down to the local municipality.
So the other reason why we need to get together is because there are implementation issues that would need to be sorted out. And that can't be done by the Board of Health. That needs to be done by all the people involved in the issues. So that's number 2. By the way, Jerry, I'll repeat, we're 47th out of 50 in terms of COVID. So, so I'm thinking that the state has done a more than reasonable job. And if I recall, if I go back in time, I remember any number of proclamations by the governor's office about what to do and when to do it. So I take exception to that. And
Well, again, proclamations, Robert, if you read them, you will see that the proclamations are not mandates. Now, I would ask you this. What is the time frame that you would expect if we follow the course of holding some meetings, some meetings, some number of meetings, the formation, as you refer to the task force? When would you expect to reach a determination? Because as we are speaking, we know that the latency in the appearance of the disease can be as long as 10 days. We know that the illness itself can have a much long duration. We know, as has been said, that an ill person may linger for quite some time. So the clock is running. So I would like to understand what you would propose as a time frame to reach a conclusion on this.
So conclusion on how to how to create the operational steps, yes?
No, to whether or not to issue a mandate and under what circumstances and how to
We
implement.
don't issue mandates.
Who doesn't?
Board of Selectmen.
Oh, that's correct. The legal authority under Massachusetts General Law, Chapter 111, Section 31, is clearly and uniquely to the Board of Health, which is why you see that in all of the circulated mandates to date.
Right, so what our interest is understanding the ramifications, understanding the rationale, and in understanding how Dover should react
Okay.
to the situation.
So I ask you again,
2 weeks.
what would you envision would be the time frame?
2 weeks, assuming you can get together 2 or 3 times.
Okay, you're muted. You.
Okay, go ahead, Dr. Peterson, go ahead. Okay, you're muted.
Bob, what would convince you that a mask mandate makes sense? How are you going to, how is any more data going to make a difference to you? I ask that because I don't think any data would make a difference.
Well, I haven't seen data that is Dover Sherburne specific. I mean, you've made sweeping statements. You've mixed information. And so I'll go through one of the things I'll do is I'll go through the slides with you and raise each question that I had. Because again, we're all here. It's September of 2021, and somehow we all made it since March of 2020. The evidence suggests that the issue can be dealt with. I just want to make sure that there's proportionality. And my goal is not, it is absolutely not to get down to zero risk. And you guys are talking about numbers that are incredibly small. So I still think we should do it offline. I think I have lots of questions about the data. I have lots of questions about the mandate. I have lots of questions about how it would be enforced and what that would mean to the community. And I want to make sure that if we're going down that path, I'm convinced that the pain is the sacrifice is worth the outcome.
So I can't let that go unanswered. You say we're all fine. So you have what's called survivor bias. You have not had COVID. You do not have long COVID. You didn't die. You have been unscathed. And that's why you can say we're all fine here. I would also say that, that you say the numbers are small. Well, the rate of rise is not small, and that's what counts with communicable disease. And I've said it a few times, and I'm going to say it one more time, because I think to have us end with you saying the numbers are small is incorrect. It's really the rate of rise that counts.
How is the rate of rise in Dover compared to all the other communities in Massachusetts?
It's pretty much the same. I mean, you can look at the slope of the curve and you can see
How does that compare to other states in the union?
To other states in the union? How does it compare to Florida or Texas? It's, it's not. Well, actually, Florida and Texas, the rate of rise is, they're actually, they have declining numbers of cases now. Things have changed for them. We're still on the upswing.
Yeah, okay.
Robert, the one difficulty in I'm not muted.
Jerry,
Yeah.
go ahead. You were about to say.
Yeah. The one difficulty in trying to be responsive to your request for yet more data, and particularly some of the data elements you've mentioned, we are up against the wall of the federal law on the privacy of health data. So much of what you've asked for is not information that is released to us. John ran into that same roadblock when the state chose to no longer publish some data elements because the state concluded that publishing those data elements, particularly for small towns such as us, would allow people to discern exactly who was ill and who was not. And that was what the state said. This is not my comment. This is what the state said. So the difficulty we have is trying to come up with data such as you request if it's not accessible to us. No, John, you laugh, but there's a lot of data that we just simply are not legally allowed to obtain.
Jerry, we could have a very, very long conversation and accomplish nothing about the reasons why the data set changed in the middle of the pandemic. So there's, I'm sure, lots of reasons, statistically, mathematically, professionally, from an epidemiological perspective, why the data set changed. And there's probably a lot of political reasons why the data set changed. That's not a subject for discussion this evening. The subject for our discussion this evening is you have the Board of Health has a very clearly defined set of guidelines. The Board of Selectmen have their clearly defined set of guidelines and objectives. We are having this conversation this evening so that our constituents, all of our constituents, can see that whatever is decided upon is not decided upon in a vacuum, that we're going to take every possible step that we can take to create the proper environment in which anything is decided, any policy is made. So we can agree to disagree. We can disagree without being disagreeable, to borrow Jim Rapetti's line. So our goal this evening is to thoroughly understand the parameters of what you may or may not do, and for the Board of Selectmen to understand how we implement and manage the results of whatever mandate or advice or recommendation you come with, regardless whether it's mask or smoking in a public or private establishment. So I believe that the one thing that everybody is agreeing upon this evening is, as Dr. Peterson said, it is not the Board of Health's mandate that you do what's in everybody's common good. You need to do what's in everybody's interest of public health. And we understand that. We, the Board of Selectmen, have to manage that process and the implications of that process. What we're asking for is open dialogue, constant review, as Dr. Peterson mentioned, and we started the conversation with, we have one town, let's just use Sudbury because they're the most recent, who mandated mask wearing, in Provincetown, the most recent town to rescind mask wearing. So when you have opposing decisions or process, that would lead us to believe we need to have open and constant dialogue as to when a mandate advisory would change, under what conditions they would change, and how that change would impact everyone, from Dr. Reinemann's preschoolers to the senior citizens. Is that, Robin, Bob, do you have anything else to add to that? So at this point in time, I think we have thoroughly addressed all of these issues. I thank everyone for their professionalism. I thank everyone for...
May I speak?
Sure. Go ahead.
Okay to speak?
Yes. Yes.
Sorry, I didn't have any audio for a second there. I hope I'm speaking for the board when I say that once we've enacted a mask mandate, that we will be thinking about it and talking about it as frequently as we meet. and reviewing data as frequently as we get it, even if that's between meetings. And if and we'll be happily communicating with people in the town administration to discuss implementation, because that will certainly raise there'll be some questions, some of which we've anticipated and some of which we probably haven't anticipated. So it'll be important to talk about that. And I'm assuming that the task force may be revitalized. I assume the same constituents that made that up earlier in the pandemic would be a useful body to discuss this with, or maybe not. We'll have to see. Steve and Jerry, do you have any thoughts hearing that?
No, I mean, you're absolutely right. People may not realize it, but the Board of Health over this time period of some 16, 17 months has frequently been in the case of almost continuous meetings. I'm not meant that to be a joke. It's lengthy meetings, multiple days a week, some evenings as well. We have not been meeting and then waiting a month because we recognize that all of this are moving targets. The data are moving targets, and you have to be responsive to the changes. That's certainly been a constant theme that we've heard enunciated by certain individuals in National Institutes of Health, that it's a moving target and you adjust your posture to the changes that occur.
Thank you, Jerry. Kate, are there any citizens that have raised questions that we have not addressed in the chat room? Kate O'Brien.
John, there's nothing in the chat room.
Okay, thank you. So we've been at this for about 90 minutes. As I said, I thank everyone who's attended this evening, the members of all the boards, our town administrator, assistant town administrator, all of from the principal at Chickering to all of the people who've joined us this evening live and through their phone in. I'm going to thank everyone for their attendance. I don't think there's anything else on our agenda this evening. Chris, anything else to add before I ask for adjournment?
Nothing, nope.
Thank you all. Make a motion to adjourn and ask for a second.
Second.
Seconded by Ms. Hunter. All in favor? I, John Jeffries.
I, Robin Hunter.
Hi, Bob Sprint.
And with that, we will, I'm sure, be in touch with all the members of the Board of Health shortly. Thanks again, everyone. Good night.